Hello and welcome to February 2nd, 2022's edition of Arizona Community Grand Rounds. As people are joining, we will do just some quick general highlights about Arizona Community Grand Rounds. Today is 2/2/22. Not too often you get to say that on your calendar, except later this month, we will have 2/22/22. But we will not have Arizona Community Grand Rounds on that day. If you're new to these rounds, we host these rounds as a collaboration among multiple organizations and partners across the state, but they're hosted and co-facilitated by Mayor Joe Gregory, President and CEO of the NARB Institute, and myself, Mark Carroll, with Blue Cross Blue Shield of Arizona and the Medicaid segment, Health Choice. We're pleased to host a series on the first Wednesday of each month at this time from noon to 1 p.m. Arizona time, and have been very fortunate, as we are today, to have a panel of incredible presenters and experts. We've been very fortunate to continue to have presentations from folks in the state and around the country on emerging topics of interest for us, both related to the pandemic and on other key topics of interest. So if you have topics that you'd like to share with us, please feel free to do so. Just general housekeeping for today's session. Everyone is joining on mute except for the panelists, who I'll introduce in just a second. But please feel free to ask us questions through the Q&A and the chat function. Today's session will not be a presentation section as much as a Q&A conversation. And so we invite your comments and questions, and Mayor Joe and I will do our best to keep track of those, monitor those, and forward those to our panelists as we can during the hour. Our presenters are noted on the introductory slide, if you're able to see that and have joined through video. They're Doctors Dave Engelthaler from TGen North, where Dave's the director. Kiran Raman, who is the medical director. Dr. Raman is medical director for the Bureau of Epidemiology and Disease Control at the Arizona Department of Health Services. Dr. Rebecca Sunenshine is medical director of disease control at Maricopa County Public Health. And Dr. Robert Orenstein is the chair of infectious disease at Mayo Clinic in Arizona. I think I have one more slide to share. Jen, if you wouldn't mind advancing to the next slide, which is just the topic for next month, which will be on March the 2nd, a 3/2/22, where Dr. Peter Rowe, Distinguished Professor of Pediatrics from Johns Hopkins in Baltimore, will be talking on long COVID and the information on emerging pediatric research and how that's been informed by some decades of work in the field of chronic fatigue syndrome and related conditions. So with that, we will begin today's session. I want to thank everyone for joining and thank our panelists for being here with us today. Dave, invite you to go first, if you wouldn't please, and chat a little bit just about genomics and things related to the Omicron variant, and maybe what is this thing that my wife tells me that I should pay attention to called the stealth variant?
Yeah, happy to. Thanks, Mark. And it's good to be back here, especially with this panel again and continuing this conversation as we really have shifted into a completely different phase of this pandemic. And hopefully we can really start talking more and more about endemic disease. I'm not going to give a presentation, as Mark said, but I do want to show a couple visualizations just to get everybody up to speed, and then we can ask questions after others have made comments as well, for sure. But we all know we're living in the age of Omicron. I'll just bring up the make sure I have the right one in front of me, the Genomics dashboard, and this has been the same dashboard that has been updated really now for I think about 14 months. We've been doing the genomics at TGen since really the beginning of the pandemic and following all the different variants. We're not going to get into that cool graph down there on the bottom of the screen, which is just really demarcating the shifts in the variants, but we can see it in this bar graph on the on the left-hand side, and I'll just zoom in on that. And sorry, it's probably a little big. I can just make it a little bit smaller, and hopefully everybody can see this in the screen. We're just looking at across months. We knew that we've been shifting in variants over, especially throughout 2021, and Delta became dominant. And then all of these sublineages, and sublineages is going to be somewhat important to the conversation of Delta were showing up. So all these different purples that we were seeing, these are all different parts of Delta. And then Omicron came in December and gave us about, by the end of December, it was about 27% of all the genomes that we were seeing in Arizona. And now in January, it's essentially 95+% probably for January. We do still see some Delta hanging out there, but it is really rare and is becoming rarer. Let me just pull back out of that. And I'm going to move over to the Omicron tracker slide. Now, it looks really boring because if we look at, this is the second week in December, going into the third week, this is when Omicron first showed up in Arizona, and the majority was Delta. And then we just saw week after week after week, Omicron just became more and more till now, this most recent week. We are at 99.7% of all genomes are Omicron. And I'm going to zoom into this too, because there's little graphs or little bars on the top of this graph. And we can see that there's a couple of different subvariants we're starting to talk about. BA1 is the dominant one. Almost all Omicron around the world is what we call BA1. And then there's another lineage called BA2. And in Arizona, we are seeing some BA2. We've been seeing it over the past few weeks, not really rapidly growing, but we're getting about 10 to 20 per week. And a lot of this has to do with an outbreak, apparently, with ASU, and ASU is doing a lot of that sequencing. But we do see this BA2 showing up in cross-border populations, people coming in from other countries. But it is still incredibly rare when compared to the rest of Omicron. And then at the very top of this, we can see this week, we've had 2 Deltas as well. So Delta's not completely gone, but for all intents and purposes, it appears to be gone. And that's pretty much what I wanted to show on the tracker. Let me just pull up one more thing on the genomics, if you don't mind.
Yeah, of course. And as you're doing that, what we'll do is we'll put into the chat, if you're not familiar where to find this tracker that TGen does, we'll actually put in the chat the link to that so everyone can be reminded where to connect to that.
And I said I wouldn't show slides. I'm not. I'm just going to show one slide. And this is just this visualization. A lot of people have seen this already. I've used it a lot. Just looks at, this is why Omicron is so incredibly different, is that it has picked up a crazy amount of mutations, especially in the spike protein. We're looking down on the top of the spike protein where it interacts with the ACE2 receptor on human cells, and all the yellow parts in this image on this cartoon on the left-hand side are the different mutations that are showing up. And then we can look in the cartoon on the right-hand side, the red dots represent new mutations versus what Delta had. And Delta already had a lot of mutations. Omicron just has so many more, and it is really structurally changed the spike protein and has changed how the virus now interacts with human cells. And it's actually ended up changing then the epidemiology of the disease, what we're seeing across the population. All of that because of this enormity of these mutations. Now, the last image I'll show is just to go back to a web image. Let's see, is that the right one? I believe so. Oops. And looking at this particular tree is pretty interesting. This is just looking at all the mutations that are associated with the different major variants. So alpha's here in pink, blue is the beta, here's delta. And these are all pretty closely related, and it's an evolutionary series of mutations that has led to what was happening with those variants. Up here is Omicron. Look at this very long branch going all the way back, and our best guess is the most recent common ancestor of Omicron with other SARS-CoV-2 viruses was back about June of 2020, back really at the beginning of this pandemic. So this thing somehow has been out of circulation, this particular lineage, yet it just pops up in probably October. We didn't first know about it till November of this past year with all of these mutations is a very strange thing. So these mutations are what is making it act differently. So we can answer that question. Why is it acting differently, both clinically as well as epidemiologically, as well as how it's behaving against previous immunity that we had, especially from antibody, because we know that it really does kind of disregard our previous antibodies, and a booster helps only because it gives us a whole lot of really lousy antibodies that can really help with neutralization. But overall, all those mutations are preventing antibodies from neutralizing this, whereas the T cell immunity still seems to be holding really strong. But that part has changed as well. But what we don't understand is a couple of the questions of where did this come from? How did this actually occur? This is really a big mystery. There's a couple of hypotheses, and we can talk about those as well. And that BA2, which I think we see here in the red, as I mentioned, it's a very small percentage. It may have an ability to transmit a little bit faster, but that has not been actually shown empirically. It's only been in a really one population studies, two different looks at it. Looks like it might actually transmit faster in a population. We really don't know that for sure, and if it is, it's probably only by a fraction. But for all intents and purposes, they're both Omicron, and the only thing that's stealthy about it is some tests actually weren't effective at identifying this one as opposed to the original Omicron version that we saw. So,
but to that point, if I may, Dave,
yeah.
That PCR testing still picks up all the variants, correct? It just maybe rapid testing does not do so.
That is correct. It does look like all of the PCR tests that are in use, certainly all the ones that have approval to be in use, are detecting Omicron without a problem, and probably the vast majority of the rapid tests as well. There may be some that are affected by it because those are based on the spike protein, and the spike protein is changing.
Great, thank you so much. Hey, Dave, a question I'm going to come back to in a little bit that's been asked in the chat, because I want to hear about some of the epi evolving from others first, but has to do with what should we be thinking about in terms of other strains around the world, and maybe you can help us understand if it's meaningful to worry about where the nomenclature comes from, such as A and B. But Dr. Sunenshine, I'm going to turn to you. Thoughts, comments on the epi of what you're seeing from Maricopa County?
First, I just want, because following Dave's comments about the cluster of BA2 in Maricopa County, we've been lucky enough to partner with ASU, and we've actually just completed all of the interviews for those individuals. So we are hoping to have some local data on what BA2 looks like. I don't have the data in front of me, but I will tell you that just sort of anecdotally, it's looking to be just as mild as the rest of Omicron, although I know that it's not mild for everyone, but comparatively to Delta and the other strains, it's certainly milder. What's hard to tease out, though, is that an artifact of it occurring in younger populations. So that's always difficult to know. Regarding the epi on a very broad scale, I can't wipe the smile off my face. Our epi curve just has descended so drastically in the last week, almost at the same rate at which it rose. So CDC has been known to call it an ice pick rather than a wave. It literally looks like an icicle. It's coming down so quickly, and we are now, I think, more than halfway down that other side of the icicle, which just brings so much joy to public health, because we have been really Fred Flintstoning for a long time, trying to catch up on all of the cases and contact investigations. And I think what I'm most excited about is that enough data have come out about the effectiveness of community-wide contact tracing, particularly in the United States, that it just, I think, something that local public health has known for quite some time. It's not an effective strategy to prevent COVID at a community level. contact tracing and case investigation is incredibly effective in the beginning of an outbreak, in an enclosed outbreak, in a facility, in a jail, in a school, all of those things, maybe even in a confined business. But at a community level, it just doesn't really work. And it's been really draining our public health workforce. So in the last few weeks, CSTE, ASTO, and NACHO, which are all the state and local public health groups, have gotten together and wrote a letter to CDC saying it's time to stop expecting all of local public health to call every single one of these. We hit 16,000 cases in a day, and ask them who they've been in contact with for the last 2 days before they got sick. It was truly ludicrous. And they finally wrote this letter to CDC and said, you've got to stop expecting that of us, because it just is really tearing down the workforce when we know that there are things that are more effective, like focusing on clusters and high-risk populations and making sure vaccination gets out and people wear masks, things like that. So that letter went out, and I just heard this morning that CDC is saying that they're going to change their guidelines and remove that strong recommendation for contact tracing to be done at a community level. So that's going to be a really big change for public health. And I think it's the next step in moving toward endemicity. And I'll stop there.
Oh, that's great. You covered a lot there. Thank you for the update on the BA2 and how that's being tracked and considered. That's super important for us to be aware of, as well as to offer what reassuring pieces of information we have about that too. I think as you mentioned. Before I ask Dr. Rahman to speak a little bit from the perspective of ADHS and the state and some of the therapeutics that are coming in to help us. I don't want to miss the opportunity, Rebecca, to thank you, to thank Kieran, to thank all of our leaders, everyone working in public health for the tremendous response over the past almost 2 years now. And whether that be contact tracing in sometimes very difficult circumstances and situations and tragedies in many people's lives, as well as in other types of follow-up. Just a really Herculean response. And we're so fortunate to have experts like both of you, well, for everyone on the panel, but also just a tremendous commitment from our public health workforce in Arizona. So thank you. Kieran, can I ask for some of your thoughts, just from the perspective of where things are now and what's top on your priority list with the therapeutics team at ADHS?
Absolutely, and thank you, Mark, for those remarks. Especially appreciate this opportunity to speak on behalf of ADHS as to the role of the state health department for the COVID-19 therapeutics. I'm going to provide a high-level overview of the operational process that we are handling at the state to help give some insight into how allocations are determined and how sotrovimab and antivirals come through. So we serve as the middle point between federal and facility partners for both the monoclonal antibodies and the antivirals. So on one side, we're working with HHS, which distributes these federally procured therapies to all states. And on the other side, we also partner, of course, with the facilities and pharmacies that utilize, administer, distribute, et cetera, these monoclonal antibodies and antivirals for all eligible patients. So essentially, we serve as the allocator of these therapies for facilities and providers across the state. And we receive a set distribution of each of these therapeutics for each 1 week cycle. So for sotrovimab and Evusheld, that's coming through to us at a set number of courses per week. And so we're not receiving an allocation of the REGEN-COV and BAM-EDI any longer because of their ineffectiveness against Omicron. And as many of you are aware, the FDA has actually removed authorization of these therapies in the US under the EUA. So they're on indefinite pause, so they're not coming through. And then so we're left with sotrovimab really for treatment. And the allocation to the state is really extremely limited, with requests from facilities far outweighing demand To put numbers in perspective, we can receive upwards of 10 times more requests for product than supply. So every cycle we're working to try and balance that demand with the extremely limited supply that we have. And so we're trying to do that in an equitable manner across the state. And so to be as fair as possible, what we do is follow an allocation protocol that first determines allocation at the county level by examining county population metrics, by looking at US Census data, and then we look at ED COVID burden. And so this is pulled weekly by our data teams at ADHS directly from EM resource. And so we then take this ED COVID burden data and have an aggregate number for each facility and network across each county. And so we take that percentage that is based off of the county allocation to apply that to the network and then allocate out based off that number. I hope that was somewhat clear. It's a complicated process, but very data-driven to be as equitable as possible. We also, of course, there are clinics and other smaller practices that don't fit into this model. So we carve out some extra for that and to make sure to serve that need in the population. And then there are stringent reporting requirements that are put into place by our federal partners. And so those facilities that are reporting as required via HHS reporting requirements, they get allocated a little bit extra if we have extra in that cycle. Definitely not guaranteed given how limited our supply is. Given that sotrovimab is an extremely limited supply, many hospitals and clinics, and perhaps Bob can speak to this a little bit more, but many hospitals and clinics are following NIH guidelines for prioritization. And so they've put in some prioritization criteria. So those patients who are most vulnerable to severe disease from COVID-19 progression will be the ones to receive the treatment. So this means that some eligible patients that fall into that EUA treatment criteria may not receive monoclonal antibody treatment, just given how limited the supply is across the state. And so that's the frustrating reality of having very limited medication to allocate out. So moving on to antivirals. So we have monoclonals as kind of the one whole piece, but then antivirals have come through as an outpatient treatment avenue for helping support some of this extremely high COVID burden that we've been all facing across the state. So we've been working with federal pharmacy partners. And so how the allocation works for antivirals is that it's a biweekly cycle allocation. So we get allocation to the state based off of a 2-week supply. We receive molnupiravir and Paxlovid every 2 weeks from HHS, and that supply is then allocated out to a proportion of that is allocated out to each of the 36 pharmacies that have been selected. Those are Walgreens, CVS, and Walmart pharmacies across the state. These have been selected because they're in high SVI areas as mandated by our federal partners, and they also have available staffing to handle the influx of patients asking for these medications or coming to fill prescriptions. Operationally, these pharmacy partners were verified federally, but also have committed to daily reporting requirements as needed, as necessitated by HHS, and that includes inventory and also utilization metrics. And they are also utilizing internal processes to shift supply between sites based on demand and utilization between each cycle. So I wanted to just highlight that given that Paxlovid in particular, which is in limited quantities, is so limited, VAPAC, which is our vaccine and antiviral prioritization committee, met in early January and approved prioritization criteria for patients that prescribers are strongly recommended to follow. We initially started in Tier 1, which included individuals 70 and older and those eligible under the EUA with major immunocompromise. This past Monday of this week, 2 days ago, we moved to Tier 2, which includes all those in Tier 1, plus any individuals age 50 and older with one or more CDC high-risk conditions. So that was a lot, but our hope is through VAPAC and by antiviral allocation or with the allocation protocol, we are ensuring that these therapies remain accessible to vulnerable patients across Arizona. And that's all I have. Happy to take
thank
questions.
you. No, that's really helpful. I mean, it is a lot because there are a lot of things going on, and that's quite fortunate because we want a lot of therapeutic activity. that's potentially promising. The challenge, of course, as you noted, is limited supply. There was a question in the Q&A around how therapies are run through allocation, and that includes the oral medications. I think you answered that because some of the newer antivirals have to go through that allocation methodology, because that's how these therapies are getting to states right now. Hopefully supply chains will be improving for that. How many pharmacies did you say again? It was in the 20s, was that?
36, actually.
36, okay. So that's more than there have been. And you've looked at that through the lens of the map, counties, geography, and just an equitable way of accessing therapy, correct?
Right. Those pharmacies are all in locations with high social vulnerability indexes. So all areas that have populations in extreme need. And so those are, federally supplied information to determine that.
Yeah, great point. And I want to thank you for the inclusive way that you've brought in experts from different systems to help inform VAPAC and some of that decision making and have that aligned, of course, with CDC and national best practice. Challenging to do that. I think we all know folks who, in an ample supply era of sotrovimab, the monoclonal that is effective against Omicron, that more people might have been able to receive it, but the supply, unfortunately, is not ample. And Kieran, I've personally witnessed how you've just helped get supply to different parts of the state that have been short during difficult times. So thank you.
Thanks, Mark.
I'll get to a couple of questions. Actually, there was a question about therapy. Bob, this could be a good time to ask your perspective just from Mayo and what you're seeing in the use of therapies, because not all therapies are new, right, Bob? There are therapies that have been approved antiviral inpatient that are now being used more outpatient, like remdesivir. And there's a question in the Q&A about fluvoxamine. I wonder if you could comment on either of those or any other updates you'd like to offer.
Sure. Thanks for having me to share a little bit of input on our situation. Because of the shortages of both sotrovimab and the shortages of oral antivirals, we made a decision back in December that we would use the data that had been presented in abstract form at that time, showing that 3 days of IV remdesivir was highly effective at preventing hospitalizations in patients with COVID-19. So back around Christmas, we pretty much pivoted, since we weren't using the monoclonal antibodies anymore, to doing 3 days of remdesivir at our site where we'd been giving monoclonals, and then using the sotrovimab when available for the really high risk patients, those in tier 1. We have a large bone marrow transplant and solid organ transplant and cancer population. And so that group was primarily targeted for the use of the sotrovimab. And then we used the monoclonal antibody scoring, which is based on risk, to identify patients that would be at risk for complications of COVID-19, and then used remdesivir in that population. And that's been very effective. We have prescribed almost no oral antivirals from Mayo. We don't have access to it. And even when we've tried to prescribe it, it's been very difficult for patients to find pharmacies within their neighborhoods that they could actually get it. So though we would be interested in prescribing some of the oral antivirals, we really haven't moved in that direction, primarily just because of limited supply. With regard to fluvoxamine, fluvoxamine's been around a while. There's been data presented since the early Delta era on fluvoxamine. And there was this large study, multinational study called, I believe, Together, that looked at fluvoxamine, showed about a 30% reduction in risk of hospitalization and death. So about the same as what you get with molnupiravir. Not great, not as good as what you see with either remdesivir given IV or Paxlovid. So we have not used fluvoxamine for that reason. We pretty much stuck to those that seem to offer the greatest benefit. And then I'll point out one other thing about the data for any of these products is you have to look at not just the relative risk reduction, but actually look at the percentage of people that end up hospitalized and die compared to those in the placebo arm and those in the other arm. These studies, most of the patients in these studies, the risk is 5 to 6%. So it's not a big difference between the group. The relative risk reduction appears to be large, but the overall actual risk reduction is not that high. And you have to look at that because these drugs are not simple to use, particularly in the high-risk patients. Many of them are on drugs that interact. And for those of us in infectious diseases who practiced HIV back in the ritonavir era, we're aware of all the side effects of ritonavir, which is what's in Paxlovid. Causes a fair amount of diarrhea. It does interact with many, many medications. And that's a challenge for most providers to be able to identify all those medications, especially if you're going to multiple different practices. I think that would be more of a challenge. So from our perspective, we'd love to use more of the oral antivirals as to become more available, particularly in those at the higher end of risk. But in the interim, we've pretty much substituted remdesivir for those patients.
Yeah, and that flexibility, Bob, that so many people are demonstrating in different systems, different parts of the state, so key. By the way, of interest, I participate in a monthly national conversation of some scientists and folks involved in the response much smarter than I am, and people in other states are now actually using the outpatient remdesivir approach, trying to find the right balance because of supply problems. And there was someone at a large institution on the East Coast, I'll just leave it at that, who has a lot of connection in the idea world, but had a relative who would qualify during non-Omicron time, non-shortage times for monoclonals, but they simply couldn't find supply. So it's a real issue, and prioritizing those at highest risk and having supply available for those at highest risk is a real balancing act. So we're going to try to address some of the questions now and just ask panelists to please jump in. There are a fair amount of questions that have come from Q&A and chat. Dave, thoughts from there was a question from your perspective, or kind of, have we seen the last of the major variants or new variants ahead? What are your thoughts? Yeah,
and I've answered that question, like how many more variants will there be? And that's like asking how long is a piece of string. This virus is here, it's going to continue to evolve. We're going to see variants and subvariants, and sometimes, and hopefully most of the time, those are going to be meaningless or insignificant. Like most of the sublineages of the past have been. We've only heard about the ones that are significantly different. And so it's quite likely that we're going to see some others that are significantly different. One of the reasons I say that is we still have no idea how, and I mentioned this before, how and when Omicron really emerged and why that occurred. We know so much about this virus and this disease now, and then it just throws us a serious curveball like this Omicron. What's really exciting though, and something I just barely touched on, I don't want to go too far afield here, Mark, but we do have a little bit better ability to understand what these mutations mean when they do occur, especially when we tie it to early data. So everything that we learned early on in South Africa has held true across the world and in every community. We get this icicle looking peak with a serious spike and then a serious drop down just as fast. And it is because of this virus seems to be so much more infectious in a way that it probably, people probably aren't coughing out more virus than we were, but what it takes is a lot less of this virus to actually infect us. The way that the mutations have changed it, the spike protein, that the virus doesn't have to essentially fuse with the human cell like it used to, a process that's fairly inefficient, and then some of that viral genetic material can go on to cause the cellular infection. Here, the virus is now binding really tightly and gets endocytosed inside the cell much more efficiently. It takes a lot less virus, and therefore it's most likely a very much a lower infectious dose of this virus, which means that things like masks and whatnot are even less effective because you just need a few virus particles to get through. And so as this, and there's a whole bunch of other things that have changed about it, but what it has changed is it's made it more quickly spread. Secondarily, probably it's made it now this milder course of illness for most people. That it really has an affinity for upper airway, bronchial, and nasal cells, as opposed to lower lung cells, which is very different than what we were seeing before. And so this is now really starting to act more like the common cold coronaviruses in large part. And because it is so omnipresent right now, it is likely that we'll see versions of this milder, but continue to change. And so, yeah, we're going to continue to have variants. The next one will be pi on the, if anybody's keeping track, on the Greek alphabet.
They're not going to skip pi?
It seems very friendly. And strangely enough, some people like my son can do the number, count out the numbers of pi in his head out to 250. So I don't, people love pi. And I think it'll be fine. But yeah, no, I think we're going to see it and likely have to continue to update the vaccine if we want to try to keep the amount of virus spread low. We've always talked about, well, we used to talk about having a universal cold vaccine. This is probably going to get us going in that direction.
Oh, thanks. Hey, a quick thought for you or Bob, or question, I should say. Asymptomatic or super mild clinical infection for someone, maybe someone even, regardless of vaccine status, I'll just ask, what do we know about T cell response? Is there anything that you might be able to share?
Dr. Orenstein, I'll let you go first. If you have something, I can.
Yeah, I don't know what the T cell response would be to asymptomatic infection. Don't know whether there's good data on that. I can tell you that, we know from the beginning of the epidemic that those with the more severe disease tended to have the best overall breadth of immune response. But I don't know whether asymptomatic infection is enough of a trigger for an adequate T cell response. Maybe others know the answer to that.
I mean, maybe there could be a flip that, in fact, if folks have a very mild or asymptomatic infection, it's because they already have a T cell protection level. That got a sort of head shake from Rebecca. Not sure about that, but I was trying to find something positive also for us moving forward. But any thoughts? Any more thoughts on that, Dave or Rebecca?
Yeah, let me just jump in real quick. There has been a few studies, and actually a recent one that was really more focused on Delta, and probably no reason to think too much differently about Omicron, that asymptomatic infection does typically result in a very robust T cell response, but it's variable because there's different reasons why, as you were getting to, different reasons why people have an asymptomatic infection. And there's some really interesting complexities about what's driving that. Is it your mucosal immunity? And that gets activated differently than your cellular immunity, which actually gets more activated because we actually will swallow virus and we actually activate immune system through our gut. And there's multiple reasons for that. So, but either way, we still end up with pretty significant T cell and B cell immunity with actual asymptomatic infections.
Thanks.
And I will add, and I'm curious, Dave or Bob or anyone on the panel, if you've seen good data, but I've actually seen some things that I haven't been able to verify with, I would say, with good science, that it's looking like a much higher percentage of Omicron is actually asymptomatic than prior strains. And I saw one quote that I would love to know you think there's any merit to it that up to 80% might be asymptomatic? What have you seen on that?
Well, the studies I've seen and pretty interesting is, looking for asymptomatic carriage. And there's been a couple of reports on this, which led to like even the EU saying, we believe that 50% of the population will be infected in the European Union. In South Africa, when they were doing studies prior to Omicron, they were identifying 1 to 2% of the population carrying around, asymptomatically carrying around the virus. During the Omicron peak that they were experiencing, they were getting up to 30% or more of people asymptomatically infected. And now you think 30% of the population, that way it easily could be, if you're looking at actual people who have the virus, that could be 80, 90 or more % of people that actually have the virus will have asymptomatic carriage. And that doesn't seem unreasonable and matches up with at least some of the reports I've seen.
I can tell you that in our preoperative screening program, during the peak of Omicron, we had about 10% of people that were just coming in for pre-surgical testing that were positive asymptomatically.
Yeah, I think still so much more for us to learn about this moving forward. Frankly, I wish that some of the odd symptoms I have that are rapid test negative would in fact be Omicron, so I could know I was done with it. I think I've talked to a lot of people who feel the same way. But it's important for us to remind ourselves, right, Rebecca and Kieran, that that Omicron is still serious for folks who have risks or who are older, and that ice pick curve for the prevalence has some curves coming behind it for hospitalization and fatalities. Am I right?
Yeah, I think I'm glad you brought that up. I think it's really important. I saw one of the questions in the chat was, well, why does it go down? Whether it's an ice pick or a wave, why does it go down? And not everybody did a great job of predicting it. So we can't actually predict it from an epidemiologist perspective. It goes down when it hits that critical threshold or tipping point, when enough of the population is either immune because of a prior infection, vaccination, or both, that it just runs out of places to effectively infect, and you dip below that R0 of 1. And that's how I think of it. When I heard those estimates from WHO that 50% of the population was going to be infected, and based on what we were seeing in public health and the rate of rise of that epicurve, I believe it. I really believe that half the population will likely have been infected when this wave is over. I knew that we would get to that point faster because even though I think it's like 55% of our population is fully vaccinated, if you then take 50% of the population having immunity from infection, that essentially reaches herd immunity at that moment. And I think the big questions that I'm asking myself is that really, what we've seen so far with all the strains, and I'd love to hear from the other panelists, is that almost everyone's confident that if you get infected with a strain, that you're not going to get reinfected with that same strain for 90 days. That's pretty confident. We've also seen a ton of data to show that if you're vaccinated and you get infected, or you get infected and then you're vaccinated, that you're like, they use this word super immune. So that probably is really, really strong immunity. What I'm really interested in is if you just had natural infection with Omicron, and we know that your level of immunity varies depending on your level of symptoms, how long will it be, if at all, that you can get reinfected with Omicron? And I think the good news is that we know that Omicron infection provides really good immunity against past strains. So it's going to keep Delta from coming back and Beta and whatever Alpha from coming back. I truly believe that. But when will, or is it possible that Omicron could resurge? And then I'm just going to comment on the severity because I think it's so, so important. We have local Maricopa County data. I wish I had it pulled up. I'd show it to you. It's just so profound. we have these epi curves of cases, hospitalizations, and death, and we divide them into unvaccinated and fully vaccinated. And if you look at cases, if you're unvaccinated, you're 2.5 times as likely to get infected as somebody who's fully vaccinated. And that's good, that's helpful, but that doesn't really blow anyone away. But when you look at hospitalizations, you're 20 times more likely to be hospitalized if you're unvaccinated than if you're fully vaccinated. And that's not including a booster, by the way. And then the third one is death. You are 75 more times likely to die if you're unvaccinated than if you are vaccinated, just with that 2-dose series. And so back to your point, if you are older than really probably 55 or 60, if you have chronic medical conditions, Omicron can still be very, very severe, but the vaccine, even just a 2-dose series, although I strongly recommend a booster, will keep you out of the hospital and keep you from dying. And it's so important for individuals with high risk to make sure they're vaccinated. And I'll stop there.
No, that's helpful. I really appreciate that summary. It's an important reminder for us that that boy, we take solace and express some dare I say cautious optimism and even joy at the decrease in cases. This pandemic and the Omicron surge, such a dramatic impact on communities, delivery systems, and public health in our entire state and country. But there are plenty of folks that are still at risk and unfortunately being hospitalized and some dying. And there's a delay in that curve, right, Dr. Rahman?
Absolutely, yes. And so we see that. We've seen that with Delta. We've seen it with other previous waves. It's coming. I mean, we've already gotten reports of higher fatality counts. So it will come, unfortunately. And given our population, which tends towards more elderly in Arizona, unfortunately, those that have not been vaccinated are at the highest risk.
Yeah, just an important reminder for us. I know it certainly is for me and for members in our communities of trying to protect folks, continue conversations with communities, with participants in sessions like today, and with you and your communities are the best ways that we can protect each other and continue to learn. While we all hope this becomes the common cold in years to come, we're not quite there yet. Any comments from anyone on the panel in terms of what you see in the future related to, or what you're hearing, or what may be under development of newer vaccines or combined vaccines, with influenza, for example, testing? Any thoughts from anyone in that space? And I know it may be a little bit too early to comment on some of this.
I think it's pretty much on people's radar, whether or not it is felt, at least on the vaccine side, that Omicron or whatnot, the variants that are coming through have settled down enough to create something that we can hang our hat on, is the question. But certainly if we get to a point where it's a steady state and we're not seeing these kind of multitude of variants coming through every few months, there's definitely, a lot of research that will go into creating something that we can have, every winter, just like a flu shot.
And I think I mentioned this last time, but we have been in talks with Moderna, and they have actually already created a vaccine that combines both flu and multiple strains of COVID-19. So it's just a matter of, is it worth getting to the point where you mass produce the vaccine and get it out? And what is the right timing to do that? You don't want to do it too soon, because you want to make sure that the vaccine will be used and that you're actually giving it to people who need another vaccine. And I think a lot of people have to kind of combine data to figure out what that timing is.
Yeah, thank you. I just brought up while we were talking, my computer's bumped into a different screen, so sorry about me looking over. But when we look at just the hospitalization for COVID diagnosis in Arizona. This is the entire pandemic showing here, which you can see is this dramatic spike, but really importantly, these reductions in reported hospitalizations over the past week or so. So this is a real trend that you were just saying, Rebecca, that certainly you're seeing in Maricopa facilities. A couple of comments have come in the Q&A and chat that there's probably some geographic variation across the state, right? That the curves are not exactly the same by every county and geography. We recognize that, and it's important for us to be aware of that. But you know, pretty dramatic sequence that we've had in Arizona over the fall to winter. Hopefully, this will give us enough immunity that we can have some reprieve from things, and hopefully, based on everything we've been talking about, that there will be a combination of different types of immunity in our bodies to be able to fight off either a future return of Omicron if it happens, or additional variants.
One of the things to add, and you can see in those graphs, you don't have to pull them up, but when we look at some of the more serious outcomes, we look at ICU usage and ventilation, intubations. The peak of those was right about the time that Omicron first got into Arizona. And it has been dropping and declining since then. So that is the same trend that has been seen almost everywhere. So that is given the fact that those are actually declining, even in the face of, we're seeing 400, 500, 600% increase in the cases the way we count them, and probably a lot more virus than that spread. That really is good news. The danger hasn't gone away for everybody, but it's really gone away for everybody who isn't high risk. And pretty much, if you're high risk, you can really decrease that ongoing risk by staying immunized, staying boosted, because a whole lot of lousy antibodies still helps prevent getting that bad response. But that T-cell immunity you get from vaccination is so critical. One other piece on that rural, or on that question, Mark, about other parts, other regions, and just think about rural. The question was, does it hit rural places later? Is it a different curve? Turns out it seems to be the exact same curve shape everywhere, but sometimes it starts later. In Arizona, we started later than the East Coast states, and some of our rural communities started later than some of the more populated communities. But it looks like every county in the state of Arizona has hit its peak and is on its way down. Some are just declining really fast now, and others are just starting their decline. So hopefully we're all in the same basket here. But yeah, it does take some time sometimes for a virus to actually get out into the far reaches and find those susceptible people that are still there. Like Rebecca was talking about, it's a lot easier to find them when everybody's packed together.
Yeah, thank you. So we just have 4 or 5 minutes to go. So I'm going to do a quick sort of lightning round of some questions that maybe can't be answered that quickly. So we'll do our best. And to folks who have put questions or comments in Q&A, I've been trying to keep track of them here and respond to them. My apologies if we don't get to all of them. Any thoughts about whether we're going to start seeing variations in our viral ecosystem that we're used to, spring, summer patterns? Any quick thoughts on that?
Well, I think we're going to really get the first test of that in the next few months, because even though South Africa just had its big wave back in November, their winter will be coming up here as we get into spring. They're getting into fall, and that would be getting into a more winter-like season. It may be too early for them because they're going to still have a ton of immunity from this massive Omicron wave. And it may take longer to get, look at Northern Hemisphere, where now it'll be 6 months or 9 months since people were infected, to see, do we get into a seasonal curve like that? I think the one thing we can't predict is, and we didn't even get to talk about where Omicron might have come from. That could happen again, and something weird pops out, and we don't really have good immunity, and it could spread really quickly again, just like Omicron did.
Yeah, 1 or 2 of you have texted me, and by the way, that's okay to do during these sessions. I was holding my phone up about the fact that, Dave, you pointed out that Omicron was first seen a long time ago, and then just came onto the world stage a year plus later. That obviously was a big issue that we're not sure what that means. I don't think we should be super fearful of it, right, Dave? But we have to keep in mind that we're still in continuous learning, and that's part of the essence of science and public health, right?
And just a small correction, it wasn't seen back in June of 2020, but that is what the genomics tells us is when the most recent common ancestor to the rest of SARS-CoV-2 is, meaning we didn't see this thing at all. And so, yeah, there could be others like that, whether or not it was circulating in animals or some very long-term infections, whatever the cause was, that could happen again.
And I told you I wasn't going to ask you about circulation in animals. Maybe that's another Arizona Community Grand Rounds, because that's a really important topic. Hey, I put in the chat where you can find the link to some of the data that we were just talking about in terms of state numbers for the person who asked that. Kieran, this is a hard question to answer, but as we learn around therapeutics, limited supply, not enough to, and always work with equitable distribution, hopefully this will improve as supply chains improves for us, correct? So that there's ample supply of antivirals in pharmacies across the state and also potentially in pharmacies within delivery systems, right?
Yeah, absolutely. As supply increases, then of course we can allocate more. And, of course, the continuing frustration on the part of, ADHS as well as facilities is that there isn't enough supply. I saw there was a couple of questions in Q&A, but in regards to the allocation protocol. So essentially, just to go over it again, we're looking at county level demographic data first to ensure that there's geographic distribution of the sotrovimab. And then from there, we're looking at EM resource ED COVID burden. So how many COVID patients are coming through their ED to see, because knowing that in many cases, facilities are taking those patients in the ED who have COVID and referring them straight to MAB treatment. So, and using that as a metric to allocate as fair as possible within that network and facility umbrella, with extra going to single facilities and clinics that fall outside. But I want to also highlight, I put a couple websites into the chat. Our website is a really good resource to kind of get a level setting and overview of some of the operational process pieces, as well as find locations of pharmacies that have been allocated antivirals, as well as sotrovimab.
Yeah, thank you for doing that, because you can filter through the monoclonals as well as antivirals or Evusheld. Someone just said, hey, you didn't talk about Evusheld, the long-acting protective antibody. Great point. Super limited supply, but something important for us moving forward. And information about that and where that's available is also on the link that Kieran has shared. So we've run out of time. My apologies for questions that were asked that we missed. None done deliberately. So if you have additional questions that you'd like to ask, we'll try to be available to answer any of them or connect you to the experts here and the links that they've provided. I just wanted to express a few notes of huge thanks. Thanks to all the panelists, your expertise, those of your teams, and everyone working in public health, direct healthcare delivery. We know this is still super hard on everyone. While we're pleased to see that curve coming down, we know that everyone's really working extra hard, and it's been really just an extremely difficult, not just 2 years, but past 30 days even. We know this is super impactful on our communities and a lot of tragedy that hopefully collectively we can continue to support and support resilient responses that'll be sustaining across time for us. A lot of uncertainty in the future, but I'm bolstered by knowing that there are great folks in my community, such as folks here today that have joined us as expert panelists and the folks joining as participants. Together, we'll continue to learn. We will be sharing opportunities for that learning through our Arizona Community Grand Rounds, but we always invite your comments, suggestions, and recommendations about other topics and ways that we can continue to be helpful moving forward. So with that, we will close. Thank you again to everyone for joining. Remember the Groundhog Day. Groundhog said in Pennsylvania, at least back there's 6 more months of winter. I'm not sure what that means for us here, but hopefully it will influence the epi curve in the way that we need it to.
Hopefully
Well,
not
that
6
will
more
cause-
months.
Did I say months? Weeks. 6 more weeks of winter. COVID climate considerations. Have a nice day, everyone. Thank you so much.
Thank
Thank
you,
you,
Mary Jo.
everyone.